Welcome to today's learning resource on management of diabetic foot infections. Diabetic foot infections, if managed appropriately, can be cured, but unfortunately many patients undergo needless amputations as a result of wrong diagnostic and therapeutic approaches. This online learning video will outline the key management approaches to diabetic foot infections. We will start by looking at the multidisciplinary approach dependent on infection classification. We will then focus on antimicrobial therapy, debridement of the wound, appropriate dressing regimen, and offloading. We will then finish with information on surgical interventions and when they should be considered within the management pathway. The management of diabetic foot infections should occur with the provision of a well-coordinated, multidisciplinary team of clinicians with varied expertise. The level of multidisciplinary involvement will depend on the level of infection. For a mild infection, a coordinated approach should involve at the very least a general practitioner. Where patient compliance or secondary complications exist, referral to a high-risk foot clinic for additional management should be considered. For moderate to severe infections, it is preferable that management is provided by a high-risk foot clinic. Where this resource is not readily available, presentation to an emergency department is necessary. Both the IDSA and the IWGDF recommend that all patients with a severe infection, some patients with a moderate infection with secondary complications such as PAD or lack of community or family support, or any patient with reasons that will make compliance with outpatient treatment impossible, should be hospitalised in the first instance. Antimicrobial therapy is strongly recommended as a starting point for treatment of diabetic foot infections. Infection severity should ultimately guide the choice of antibiotic treatment and its route of administration and the need for hospitalisation. However, use of antimicrobials can have adverse effects and also increases antibiotic resistance. Therefore, the use of antimicrobials should only be reserved for the treatment of infected foot wounds. As podiatrists, unless endorsed, we will not be prescribing antibiotics. However, it is useful to have an understanding of how the antibiotic regimen is selected, as we may be involved in the ongoing management of the patient's care. The following 3 slides provide an overview of antibiotic selection based on route of administration and infection severity, as well as therapy duration. According to the IDSA, the antibiotic therapy should be based on the severity of the infection and the likely infective agent. The selection is usually based on the best guess of what the infective agent is and whether it will cover the suspected pathogen. For mild to moderate infections in patients without recent antibiotic treatment, it is suggested that a narrow-spectrum antibiotic just targeting aerobic gram-positive cocci is adequate. The IWGDF state that if there is substantial risk of infection from MRSA organisms, then an agent active against MRSA should be considered. For severe infections in patients who have had previous antibiotic therapy, starting with a broad-spectrum empiric antibiotic therapy, pending culture results is recommended. These patients may need extended coverage for common gram-negative bacilli. The definitive therapy should be based on culture results and sensitivity of a wound specimen, and also considering the patient's response to the antibiotic regimen. For mild infections, consider oral antibiotic therapy. Compared with parenteral therapy, treatment with oral antibiotic agents is more convenient, not associated with infusion-related complications, and generally less expensive. If the patient is unable to tolerate or the pathogens are insensitive to oral agents, parenteral antibiotic therapy should be considered. For most severe infections and some moderate infections, the IWDGF recommends administering parenteral therapy initially. Parenteral antibiotics are recommended for patients who are systemically ill or have a severe infection because they achieve therapeutic serum levels faster and more reliably. After the patient's clinical condition is stabilised and the infection is responding, most can switch to oral antibiotic therapy. For those requiring prolonged parenteral treatment, for example, some cases of osteomyelitis or infections with organisms found resistant to available oral agents, consider outpatient intravenous antibiotics. The optimal durations of antibiotic therapy for diabetic foot infections are unknown. Based on the literature, 1 to 2 weeks is usually effective for mild to moderate skin and soft tissue infections, while for more serious skin and soft tissue infections, 3 weeks is usually sufficient. Antibiotic therapy can generally be discontinued when signs and symptoms of infection have resolved, even if the wound has not healed, as the antibiotics are employed to treat infection, not to heal wounds. Extended treatment may be needed for immunocompromised patients, for wounds that are poorly perfused, deep, large or necrotic wounds, or for osteomyelitis, but this decision should be accompanied by clinical re-evaluations to support the treatment strategy. For diabetic foot osteomyelitis, IWGDF recommends no more than a week of antibiotic therapy if all infected bone is resected and 6 weeks of antibiotic therapy for patients who do not undergo resection of infected bone.
The majority of infected diabetic foot ulcers will require careful cleansing and debridement. The aim of these procedures is to remove devitalized tissue that can act as a barrier to wound healing and promote an environment that fosters infection. Sharps debridement or surgical methods, if required, are strongly recommended as being the best techniques. For an infected wound, scalpel debridement aims to remove bacteria along with non-viable tissues such as debris, eschar, biofilm, and surrounding callus. Vascular supply should always be determined prior to undertaking scalpel debridement on any wound. The IWGDF recommends that we do not select a specific type of dressing for a diabetic foot infection with the aim of preventing an infection or improving its outcome. Systematic reviews of various wound dressings and topical antimicrobials have found no evidence that any specific type of therapy is better than others. In general, wound dressing guidelines for diabetic foot ulcers should be followed, for example, according to exudate level. Diabetic foot ulcers with a heavy exudate need dressings that absorb moisture, while dry wounds need topical treatments that add moisture. Dressings should also optimally be changed at least daily, both to apply a clean wound covering and to allow careful examination of the infection's progression. Topical antimicrobial agents should not be used alone in those with clinical signs of infection. However, common topical antimicrobial agents that may be considered for use as an adjunctive therapy for diabetic foot infections include dressings containing silver or sulfur-sulfur-diazine, polyhexamethylene beguinite dressings, iodine dressings, for example, povidone iodine or codexamyl iodine, or medical-grade honey. Total contact casting is the offloading gold standard in managing diabetic foot ulcers. However, in the case of a diabetic foot infection, total contact casting is contraindicated. Applying a total contact cast makes it difficult for the clinician and patient to visualize the wound for evaluation of response to treatment between changes and is therefore generally not appropriate for infected wounds. Removable knee-high walkers such as cam walkers and crow boots should be considered as first-line modality for healing ulcers with active and mild infection that is not yet under control and which requires frequent local care or inspection. This also includes ulcers with a mild infection that are under control. When a knee-high device is contraindicated or cannot be tolerated by the patient, consider offloading with a 4-foot offloading shoe such as a post-op Darko shoe. Ankle-high offloading shoes compared to knee-high devices have lower efficacy and/or longer healing times associated and pose a higher risk for infection and hospitalization. It is important to consider the need for surgery early in every infection as this may be associated with better outcomes. Surgical interventions may range from minor debridement or drainage to extensive resections, revascularization, or major amputation. As podiatrists, a sound knowledge of surgical interventions will help in instances when patient education regarding surgical options is required. In non-urgent infections, the initial surgical intervention should be limited to incision and drainage, with further resection needed only if the patient is not responding. The aim of surgical treatment is to drain any deep pus and to minimize tissue necrosis by decompressing foot compartments and to remove devitalized and infected tissue. Bone resection and amputation is often necessary when there is extensive soft tissue necrosis, osteomyelitis, or the need to provide a more functional foot. Major amputation should and usually can be avoided unless the limb is non-viable, is functionally useless, or is affected by a potentially life-threatening infection, such as gas gangrene or necrotizing fasciitis. Emergent surgery is only needed in specific circumstances, such as compartment syndrome or systemic sepsis, or gas gangrene or necrotizing fasciitis. Lastly, revascularization is a surgical intervention that may be required when peripheral arterial disease and ischemia is a complicating factor for the unresolving diabetic foot infection. Our final slide consists of the algorithm overview in approaching a patient with a diabetic foot infection. If the patient is clinically infected, you would classify the infection severity first. If the patient had a mild or moderate infection, you would assess the need for any inpatient treatment, review any available microbiological data, arrange for surgery if required, select an initial antibiotic regimen, select an appropriate wound care plan, and if they were to be treated as an outpatient, you would set up a return visit. Outpatients are usually reassessed in 2 to 4 days or earlier if the situation worsens. If they improve at this appointment, you would consider de-escalating the antibiotic regimen to something with a narrow spectrum, something that is less toxic and also less expensive. You would then reassess weekly until the infection resolves. If once the infection has been cured, you would schedule a first follow-up within 30 days, and then you would follow them up regularly from then on. At this appointment, you would also further your patient education. If the infection does not improve or worsens, however, you would reassess a need for surgery and hospitalization. You would consider deep abscesses, osteomyelitis, assess the patient's adherence to therapy, reassess wound care, consider consultation of ID specialists or microbiologists, review microbiology results and change any antibiotics accordingly, and you would also consider obtaining wound specimens. Patients with severe infections also need to be hospitalized, and you would then consider obtaining blood cultures, arranging for surgery if required, and selecting empiric broad-spectrum parenteral antibiotic regimens, and selecting appropriate wound care, which can include debridement, dressings, and offloadings. Patients who are hospitalized must be reassessed clinically at least once daily. Their inflammatory markers must be checked if needed, and the culture and sensitivity results must be reviewed. If they begin to improve, you would consider switching to an appropriate oral antimicrobial regimen and consider following them up as an outpatient. However, if this worsens, you would reassess the need for surgery, including abscess drainage, revascularization, and amputation. You would define the extent of tissue involved, and this includes advanced imaging and surgical exploration. You would consider the consultation again of infectious disease specialists or microbiologists, and you would ensure all identified isolates are optimally covered. You would then consider broadening the antibiotic spectrum and monitor until the infection improves. Below are our references. Thank you for listening to this online video on the key management approaches to diabetic foot infections.